All right, everyone, thank you for joining us today. We're really happy to bring you a new series from GlomCon to discuss high-impact clinical trials in glomerular disease. I'm Benes Srinivasan. I am the Director of Emerging Therapeutics for GlomCon. I'm an Assistant Professor of Medicine and a Clinical Nephrologist at Cooper University Hospital and Cooper Medical School of Rowan University in New Jersey in the United States.
Hi, I'm Manasi Bapat. I am a nephrologist at Kaiser Permanente in Walnut Creek, California. And today we are so glad to have an opportunity to chat with Dr. Michael Walsh. Dr. Walsh received his MD in internal medicine and nephrology training at University of Calgary. He then completed a MSc in clinical epidemiology and a research fellowship in lupus and vasculitis at the University of Cambridge, followed by a second fellowship and PhD in health research methodology at McMaster University. He's an associate professor of medicine at McMaster University in Hamilton, Canada. His research interests are in systemic autoimmune diseases, particularly ANCA vasculitis, chronic kidney disease, and end-stage kidney disease. He's the lead author on the PEXIVAS trial in plasma exchange and glucocorticoids in severe ANCA-associated vasculitis, which we will be discussing today. So welcome, Dr. Walsh.
Thanks so much, Manasi.
Our first question for you today on PEXIVAS is, PEXIVAS is the largest randomized control trial in ANCA vasculitis with about 704 patients or participants. With what purpose was this trial designed?
Thank you, Manasi. So we designed PEXIVAS just after the MEPEX trial was published, and we had completed its long-term follow-up almost at the same time. So we were struck at that time and how MEPEX, there was such a high mortality rate overall, and how it was higher rather than lower in the plasma exchange treated patients, despite a fairly dramatic reduction in kidney failure in that plasma exchange arm. So we didn't really have a good explanation for this, and I would say that that was a lack of coherence. So if you prevent kidney failure, you should delay death at least to some extent. And since MEPEX was relatively small, it was actually fairly large for an ANCA-associated vasculitis trial at the time, and certainly reasonably large for a plasma exchange trial, we were still worried how much of that signal might have just been by random chance. At the same time, we were completing a meta-analysis of all the plasma exchange trials, and they suggested that plasma exchange may be a bit more effective in patients who weren't teetering on the edge of needing dialysis. And so we wanted to try and prove whether plasma exchange was effective at preventing death and dialysis across a broad range of patients who are at risk for those outcomes with ANCA-associated vasculitis. At the same time, we had just relocated to the UK, so I went there from Canada for my training, and we saw that the approach to glucocorticoids was really quite different across different areas. And the funding competition we were going to with the plasma exchange question was encouraging us to design trials that would answer more than one question at once, and particularly questions where there would be no industry interest. So we decided to test whether or not we could identify an oral glucocorticoid dosing regimen that had effects on important outcomes as well.
Thank you so much, Dr. Walsh, for that answer. Our second question for you is, can you briefly summarize the results and their significance that debunk plasma exchange is standard of care for ANCA-associated vasculitis?
I always find it interesting when people say it debunked the practice. So I think we actually need to be really clear about the results of PEXIVAS. PEXIVAS was powered to try and find a moderate to large effect of plasma exchange on a composite outcome of kidney failure or death from any cause. And again, that's because we really thought that if we reduced kidney failure, which we thought was likely, that death should follow the same kind of route, and so that the components of the composite would move in the same direction. PEXIVAS, though, failed to find this difference. But it wasn't powered to find smaller differences, even though those would be also important, and it wasn't powered to try and find differences in each component of the composite outcome, particularly not at early time points. And we weren't the first trial in that area, so it did take us some time, but we ended up doing a fairly detailed meta-analysis late last year. And we published that one in the BMJ, where we had much better power to examine each of the component outcomes, and we were able to examine them both at the 1-year time frame and in a longer time frame. And in that meta-analysis, we found no important effect on death, but we did find an important reduction in kidney failure, and surprisingly, an important increase in serious infections, all within the first year. And all of those outcomes all those effects started to fade in the longer term follow-up. This is really important because that means that PEXIVAS unfortunately suffered from noise in its signal from two places. One was across time, and one was across the components of the composite outcome. Importantly, for lung hemorrhage, where I think there's still a lot of debate, there really is no compelling reason to use plasma exchange, as there's no apparent effect on death, which is what patients who are having diffuse alveolar hemorrhage are at risk for. And there is the chance of giving them a serious infection, which is the most common cause of death for these patients. Conversely, for those who are at risk of kidney failure, there's an important reduction in the risk of kidney failure, at least in the first year, and it comes with a concomitant risk of serious infection. So there's a trade-off, and patients will weigh these risks and benefits differently, but they do so in a way that we often just can't understand by looking from the end of the bed of the patient. We actually have to describe them to them. And so we need to be able to give them clear information on what the risks and benefits are. And so I think, this is one of those nuances where we say that plasma exchange is good or it's not good, and that's probably not quite true. It's both good and bad, and for different people, they will weigh the good and the bad a little bit differently in order to make a fairly individualized choice.
Right. So that was actually going to be my next question, that approximately 9% of patients in PEXIVAS had severe pulmonary hemorrhage. And the question is, should these patients be still offered plasma exchange? And the answer, I think, is it should be case by case, in an individualized decision.
Yeah, and so the way that I weigh this out is that I don't recommend plasma exchange to save lives. So in general, if someone has diffuse alveolar hemorrhage and we're worried that it's a bad hemorrhage, they're hypoxic or they're intubated even, we'd be worried about it. And some people have interpreted the point estimates for plasma exchange effect on patients with diffuse alveolar hemorrhage as being trending towards benefit. And there was numerically fewer deaths in the plasma exchange treated individuals with severe diffuse alveolar hemorrhage. But those deaths actually occurred in patients after they recovered and were off ventilation by and large, and they were largely infectious deaths. And the benefits were not reflected in decreased ventilation time, which you'll see in a publication coming from Lynn Fussner fairly soon. So, again, those point estimates look enticing, but they really lack coherence again with the rest of the story that plasma exchange tells. And there is moderate certainty evidence that we're going to increase the risk of infection and no certainty that we would decrease the risk of death, really. So I would generally say, don't do it. There is one scenario, though, where you might consider it, and we call that the kitchen sink scenario, where a patient is almost certainly going to die, and the risks of you doing further harm are so small that any potential benefit is probably worthwhile. When we asked a group of physicians, including critical care physicians, what would that patient look like? Could you reliably predict who it was? They said, no, you really have to take it as a case by case, and ventilation has really, and supportive care for patients with respiratory failure has really advanced a lot in the last couple of decades. And so they're quite good at getting people off of the ventilator. And so those scenarios probably don't happen all that often.
Thank you, Dr. Walsh. I think that's a very good summation of results from PEXIVAS and the upcoming trials. Our next question for you is, what do you think the standard of care for ANCA-associated vasculitis will be in 5 years down the line? We're fortunate, we have a lot of newer therapies in glomerular disease, avacopan. So I wanted to get your opinion on what you think standard of care will look like in 5 years from now.
Yeah, that's a great question. And my answer is entirely speculation. Because this field really is changing quite quickly, both because of, we have an improved understanding of how and why patients with ANCA-associated vasculitis differ and how their outcomes will differ, what the future risks will look like for them, and because of, as you mentioned, there's a plethora of new potential treatments on the horizon. And I hope that just as we've seen IgA nephropathy have an explosion of potential therapeutics, that we'll see something quite similar in ANCA-associated vasculitis also. So if I had to answer very broadly rather than specific agents, I think care will become less standard and probably quite a bit more personalized. And that's not personalized in that we'll do a genetic test and we'll have 90 panel biomarkers for everyone, but more that we'll be able to understand, even in relatively crude terms, which patients are at high risk for death, kidney failure, infection, and future relapse, and we'll be able to pair those risks and their preferences with the treatments that are best able to mitigate the risk of treatment and maximize the risks, or maximize the benefits by reducing the risks of the things that they're actually going to experience in the future. I think that that's still easily within 5 years. In fact, I'm hoping more like in 3 years we'll be able to take big steps towards that, and in the years afterwards we'll be able to hopefully be able to apply new therapies as well. I think that would be a reasonable 5-year outlook.
I think that sounds like a wonderful outcome for all of us for precision therapies for the nephrology community, similar to what we've seen with hematology and oncology over the past several years. Dr. Walsh, we want to thank you for taking your time to speak with us about this important trial. It's extremely beneficial to the nephrology and the glomerular disease community. Manasi and I both thank you for your time and sharing your expertise with us today.
Thank you guys so much for having me.